Hi, I'm Dr. Kuebler, Kim Kuebler, and Editor-in-Chief of the Multiple Chronic Conditions Resource Center, and we are pleased to introduce Richard Knight, who I recently met at the U.S. Department of Health and Human Services Agency for Healthcare Research and Quality Summit on Patient-Centered Care Planning for Persons with Multiple Chronic Conditions. I was impressed with Richard's kickoff of the meeting, the summit meeting, as the first speaker, and he provided a patient perspective on his journey throughout his course of poorly managed hypertension that led to kidney failure and eventual kidney transplant. Richard is a kidney transplant recipient of 18 years. He holds a master's degree in business administration and is adjunct instructor at Bowie State University and a founding member of the College of Business Advisory Council. He is a past president of the American Association of Kidney Patients and serves on numerous advisory boards and committees. He is a board member of the Personalized Medicine Coalition, advocating for the adoption of personalized medicine to benefit patients and health systems. As a member of the National Diabetes and Digestive and Kidney Diseases, he serves on the Advisory Council and is co-chair on the Strategic Plan Stakeholder Engagement Subgroup and participates in the Steering Committee for Kidney Precision Medicine Project and the Scientific Registry of Transplant Recipients Visiting Committee. He serves as chair of the Patient Advisory Committee on a shared project with the National Institutes of Health project, caring for outpatients after acute kidney injury. His commitment to the field has been recognized with the President's Volunteer Service Award from President Trump in 2020 and the President's Lifetime Achievement Award from President Biden in 2022. In 2017, he received the American Society of Nephrologists President's Award. Very impressive background, and we can't underestimate the fact that March is National Kidney Month, so this is a perfect segue. Richard, thank you so much for joining us today.
Well, Kim, thank you for having me. As you went down that list, brought back memories. I have been at this for a while.
And for bringing a patient perspective to this forum. As you think about being a patient, to those of us who provide interdisciplinary healthcare interventions in the patient care experience, from your perspective, help us to better understand how to provide patients like you with best care. Based on your recent experience as a patient ambassador at the Agency for Healthcare Research and Quality's meeting on person-centered care planning, what were your key takeaways, and is there anything that you wanted to add to the information collected from this meeting?
Well, I got to tell you, it was a great meeting. I was very impressed with the work that folks have done. People, background of social service professionals, healthcare professionals, patients collaborating, reviewing data. It was just a tremendous amount of information. As I like to think, when I go to a meeting like that, when I always like to think of what impact would this have on the patient? How can we go forward? How can we use this information? In a period of time where we are at and budgets and other resources are being cut, the patients are still out there. And the one single word that I use is grateful for all that I've been through. And I do have, I just want to, for the record, state that I am one of those who has multiple chronic conditions. You know, of course, I have hypertension, which is the reason why I lost my kidneys. The last time I was in the hospital, I was borderline diabetic, but I got kicked all the way into diabetes. I see a cardiologist because I recently had a fistula removed from my arm, which is your access during dialysis. It had been my buddy for 19 years, but it became a problem. And because it was removed, the flow of blood throughout my body, particularly the left side, became problematic. So I do visit. As a matter of fact, I have an appointment tomorrow with a cardiologist, primarily to monitor and everything that goes on. And of course, like everybody else with a host of other issues, from seeing dermatologists and things of that nature, I am trying to avoid obesity, but that's difficult. but what I saw was a group of individuals who had come together, had done tremendous research, had looked at some of the, we always, in the class, always talk about benchmarking, where you look at the standards and compare what you're doing to a given standard. So there was a lot of information. Now the challenge as we go forward is implementation. How do we take this and move it forward for the benefit of the patient? And of course, I always tell folks one of the key things that we must do is we simply must educate the patient more. We must do a better job. Now, the other side of that is I do understand the business model in healthcare. Primary care physicians see a lot of patients. They really don't have time to do that education. In your practice, you see a lot of patients, and you don't have time perhaps to do all the educating that you need to do. So we need to come up with a more effective way to allow those professionals to have that conversation. And when I go to many doctors' office now, I may not see the doctor. I may see the physician assistant. I may see a nurse practitioner or someone else who's able to spend time and give me that important information that I need. And I think that and I'm not separating myself from anybody else. I'm a patient. I have my issues. But so many patients aren't as familiar with the healthcare system, ways to remedy things. And I always ask doctors when they prescribe something to me, I said, do you have any idea of what this costs? Because many times that is an issue. I have to use Eliquis. It's not an inexpensive medication. And I have several immunosuppressant medications, which tend to be very expensive. My medications can cost what my monthly rent is. And that's difficult for a lot of people, myself included. But I use the word grateful because I live a great quality of life due to much of the work that you and your colleagues are doing. And I like for other people to have the same opportunity to have that quality of life.
Well, thank you. During your presentation, you provided a trajectory of your medical experience during this meeting, and you mentioned how poorly informed you were, which you just identified, and the importance of preserving your kidney function until it was too late. You mentioned that you didn't even know when you had a high protein level in your urine, what that actually meant. What specific information would have helped you to better understand how your hypertension impacted upon your kidney function?
One of the things that happens, primary care physicians, not beating up on them, they have a role and a business model. And in many practices, you can have diabetes, you could have hypertension, such as what I have. And it was occasionally mentioned to me that high blood pressure can damage your kidneys. There was not really a specific connection made between hypertension, diabetes, and loss of kidneys. There are many patients, and I've talked with many of them, that have diabetes, and they were not made aware that having diabetes could damage, or it was damaging their kidneys. And the thing about kidneys is that they will function until there's like maybe 15% functionality left. In other words, they'll go a long time. You won't necessarily feel anything. Then you have a couple of weeks of stress. You don't know what's wrong, and all of a sudden, you've lost your kidneys, and you need to go on dialysis. So the thing that I've said to the profession, and I said, I don't understand it any other way, but early diagnosis is the key. The standard practice is to refer a patient to a nephrologist when you're at CKD 4. I said, well, you're almost on dialysis at that point. We diagnose it early, educate the patient, and we have the medications now to slow the progression. So that is the single point that I share with folks. Whenever I go to meetings with doctors, I'll ask how many primary care physicians who are in the room, and virtually none. I'll say, well, those are the ones that need to be here, because they need to understand the importance of making that early diagnosis and the referral. Again, I understand the business model. You see patients, you bill and all that. But in the long run, it's going to be best if we do things early, because there's 37 million people with chronic kidney disease, and only 10% know that they have it. That's a pretty frightening.
That's amazing. Richard, as an ambassador, advocate, and past president of the American Association of Kidney Patients, I know you have mentioned some issues that you think are problematic for the trajectory of kidney disease, but in your opinion, what would you consider the missing links in the collaborative medical management of patients with kidney disease?
Okay, thank you for the question. My thoughts are that when I first entered the arena shortly after having my transplant, is I became aware of the siloed nature of the healthcare industry. And what that does is it makes it more difficult for patients to have a good, solid continuity of care. We talk about electronic health records, and we have some systems that are in place that certain practices may use, but they're not universal. And we talked about that extensively during the meeting, the need to have systems that talk with each other. And I'm a big advocate of the e-care system or planning system that was done or is being developed over at NIDDK. There were several people there, including Arlene and Jenna Norton, who were working on that system. And because it's done by the government, it's something that could be available to everyone. But again, private sector, we want to build our own. And sometimes when we do that, the systems aren't able to communicate with each other. And I think that if you belong to it, I'm not pushing any particular company, but Kaiser happens to be a model. That's an example of it. You generally will have access to all the records if you go to Kaiser because they have it within their system. The VA, for all that the ills that we talk about there, but if you go to the VA, your information is in the system so they can get access to it. So I think that that's very critical. One doc needs to know what the patient is being prescribed and why. When I had a transplant back in 2006, I had an enlarged prostate. When I went to the hospital in 2018, there was big concern. And I did go visit my my transplant surgeon after I left there and I recovered, and he said, "Well, they wouldn't know, but your prostate has not gotten much worse since 2006. It was enlarged then, but if you're looking at it now, because of your age, it would be very problematic to them." And because he had the information from 15 years ago, he was able to make that diagnosis. So I think that it's important that we do a better job of constructing systems, the electronic health records that can talk to each other. So a primary care physician or whoever it is that you might see, and I mentioned when I go to these offices, sometimes I'll see a physician's assistant or I'll see a nurse practitioner or someone else. I like that because they can generally spend the time with me and give me the information that I need. And I want to know, what do you suggest? What's going to be the best way to handle that? What should I not do? Although I've been a borderline diabetic for quite a while, I've just recently had to start taking insulin. And that's just something I'm not familiar with. So I need to have information, and sometimes I can't get all the information I need from my primary care physician. So, I think better communications, better systems that are more efficient, and we must get away. We talk about value as opposed to fee for service. We talk about value care, and we're trying to move to that. In order for that to happen, we have to be able to look at the patient in total, not just one aspect that a urologist might look at, a cardiologist might look at, a primary care, or some other practice. We need to be able to look at that patient in total because there are some things that will impact other aspects of the body.
Absolutely. And that really leads into my next question. From your experience as a professional and as a patient, you mentioned a little bit about this in your last comment, but based on the meeting that we both attended, how best can healthcare professionals promote a patient-centered care planning experience to individualize patient care and promote the best outcomes? So taking it back to the patient as being the core of care.
Well, the first thing I think is what I call the mindset, in that we look at things from the patient out. I would ask a nephrologist a question, and they would simply tell me, well, Rich, we can't bill for that. Now, from a practical matter and a business side, I understand that. But from a patient perspective, that doesn't make sense. Just because you don't bill for it, you don't want to talk about this preventative measure. And so we have to get back to the concept of value, and that value as it impacts the patient. And if we do that, then I think in the long run, people will be more efficient in terms of how they deal with patients, in terms of how they structure things. For example, during COVID, they used a lot of telehealth. Well, now that COVID is over, that doesn't mean, and you're operating in a rural area, there may be some reason that a patient has to come into the office, but if it's a follow-up visit or something of that nature, well, maybe they don't. Maybe you can talk with them via telehealth. In dialysis, people doing home dialysis as opposed to in an office setting. The machine can do certain diagnostic things that can highlight an issue if a patient has a problem. So that doesn't necessarily mean that we need to go into the center. When you ask a nephrologist if they had to go on dialysis, 99% are going to tell you that they would do home dialysis. I say, well, why don't you have all your patients doing that? So it's that disconnect right there. If the focus is on the patient, we will simply behave differently. I used to talk with people, and I have a background in accounting and finance as well. I used to always talk with people about the concept of patient-centered reimbursement. You should get reimbursed based on impacts on patient, as opposed to going down some long list and checking it off. And if we did that, you would be reimbursed for preventative things. As I used to tell people when I went to meetings, nobody wants to go on dialysis. So we're interested in going upstream, earlier diagnosis, educating the patient because they need to participate in slowing the progression. Now, does that impact you guys at a dialysis facility? Yes. But is that in the best interest of the patients? Yes. So which do we do? Right now, we let the patient go to dialysis because we don't focus on. Recently, law was passed, or executive order number 19 by President Trump, that reshaped the dialysis industry with more focus on the patient and trying to do prevention, trying to emphasize more transplants, trying to focus resources on artificial implantable kidneys, xenotransplants, using pig organs. That's a growing industry right now. So there's a lot of things that we can do if we focus on the patient and make them the center of our efforts. And even, again, do we have to, for a patient on dialysis, it's very difficult for many of them to go into the office. It's very difficult. It's tremendous. You live in a rural area. We have many patients in my organization, AKP. I'm the past president, but I'm still very much involved, that live out in rural areas, and it's just not easy to get around. We don't have the number of resources that we need. So telehealth is a tool that can be used.
Absolutely. So what do you consider the roles and responsibilities of the patient when advocating for individualized health care?
Patients have to be engaged. They have to speak out. It all starts with, it's challenging to say, but we have to let the people, the legislators, know our thoughts. And we advocate on Capitol Hill as a patient group, but we also go up there with the American Society of Nephrologists, We go up there with the Renal Physicians Association. We go up there with the transplant organizations. And we understand the issues, and it's much better coming from a patient than it is from a group that has a vested interest in something. So that generally works well. And then once we get a move, I mean, it took for years for us to get the legislation passed that is such that the immunosuppressant medication that a transplant patient takes can be covered beyond that 36-month period of time. Many people were losing their kidneys because they couldn't afford the medication. So medication that could cost $3,000 a year, you lose your kidney because you don't have that, and you go back on dialysis, which the government pays for through Medicare, at $75,000 or $80,000 a year. So that kind of doesn't make sense. So it's things like that. Right now, for example, HHS, and I forget the name of the acronym, but there's a group at HHS that makes recommendations for certain things. We are trying to get them to recommend screening for chronic kidney disease. If we do that, we diagnose it earlier. If we diagnose it earlier, we can deal with prevention. We can stop someone from going on dialysis. We can slow the progression down by 10 to 15 years with some of the medications we have available. So if we did a better job of identifying this disease early on and put that person on the path. Now, patient's responsibility, and as an advocate, I tell patients all the time, and people don't like to use the word anymore, but I'm old school. You have to be compliant. You have to follow the doctor's orders. If you're diabetic, you have to manage that diet. You have to exercise. If you have high blood pressure, you have to take your medication. You got to do your part. So I think that as we advocate, we have to live what we're talking about so that we can be in a position to take advantage of the opportunities that come available to us through improved technology, pharmaceuticals, and other medical devices that are becoming more and more available.
You started this answering this question with policy, health policy, and I believe that policy actually does drive practice, and it is important for the legislators to hear the patient perspective for sure. Richard, you've given us a lot of great information. We really appreciate your perspective. And is there anything that you would like to add that I didn't ask?
No, I think that you're doing great work down there. I visited your website, and it's just full of information, a one-stop place for people, regardless of their disease state, can go and get information, and that's healthy. And thank you for putting our website up there, Connection Us at the American Association of Kidney Patients. And I just want to emphasize that patients cannot sit out there in a vacuum. They must become engaged and involved. Education process. We are doing things now that can improve and enhance the quality of life for patients, but we have to be ever vigilant and make certain that, in this era of cutting funds, we need to make certain that monies are being spent on the things that are priority to us. And I think the health care of Americans across the board is important. So we need to support that. So I'm going to say that you continue doing what you're doing. I enjoyed meeting you up at the conference. It was a tremendous summit, the culmination of work done by a lot of professionals in your field and other fields. So I just appreciate and grateful for the opportunity to participate, and as well as have a chat with you this morning. I'm very thankful for that.
And our paths will continue to cross, I'm sure. Thank you so much for all that you've given us this morning.
You're welcome. And continue on with that great work.